Hi everybody, my name is Dr.velavan. I am a reader in Department of Oral Maxillary Surgery, SRM Dental College, Ramapuram. Today we are going to talk about stroke. So stroke is an neurological impairment caused by a disruption of the blood supply to the region of the brain. Like we have an heart, there is an ischemic attack. So the same way we will be having an ischemic attack in the brain. So where the blood supply to a region of the brain is disrupted. So other name of an stroke is called as a cerebral vascular accident. How serious is a stroke? Why you want to know about a stroke every time? Because it is about 7 lakh stroke occurs each year and over 1 lakh 67,000 death occurs, and it is the most common cause of death, third most common cause of death in US, and also it is the leading cause of serious long-term disabilities in adults. Almost around 4.7 million survivors will be there in stroke, but what is the problem is there will be always with disabilities, long-term disabilities. What is important in stroke? So why you want to know about the stroke and why you want to create awareness in the public? It is because mostly to us it is to educate the patients who is at risk and also early recognition of stroke signs so that you can just promptly act to go towards the, saving the patient's life, and also prompt transport to hospitals can be done, and also rapid hospital triage and evaluation which might make the patient to survive. What are the two types of stroke? So two types of strokes are ischemic stroke and hemorrhagic stroke. So ischemic stroke almost accounted for 70%, 75% of the strokes, where the blood vessel supplying the brain is occluded by a clot which is happening on the brain vessels, or it can be an disrupted clot which is going and blocking the blood vessels. So what is hemorrhagic stroke? It's when a cerebral artery ruptures, like in Tamil they call it as மூளையில் ரத்த குழாய் வெடிச்சிருச்சு, like. So it's like a hemorrhagic stroke. So when a cerebral artery ruptures, hypertension is the most common cause of this intracerebral hemorrhage. What are the risk factors for stroke? Most stroke victims have prior risk factors like an indication. You will almost have an prior risk factors. So early detection avoids major strokes. So when the patient has been early detected and the patient has been given a proper care and a treatment, the major strokes can be avoided. So what are the early detection signs will be hypertension, smoking, diabetes, atrial fibrillation, hyperlipidemia, age, sex, and also the family history of the patient where the patient's uh, relatives had a history of stroke. What are the symptoms based on site of the stroke? So usually when the patient is going to have a right side of the brain is going to be affected, or the left side of the brain is going to have get affected. So they'll be having an certain type of disabilities or signs. So what will be helping you in finding out the which side of the brain has been damaged. So when the patient is having a right-sided brain damage, the patient's left side will be paralyzed. Patient will be having a spatial or a perceptual deficits. Thought will be impaired. Quick impulsive behavior will be there. Patient cannot use the mirror. Difficulty performing the tasks, even toothbrushing cannot be done by the patient. Memory deficits will be there, and also the neglect on left side will be there. So that the patient will be having hemiplegia, or one side of the uh, hands and legs will be affected. So that is called neglect of the left side. So when the patient is having a right side brain damage, the left side will be affected. The same if the patient is going to having a left side brain damage, it's a vice versa. So will be patient will be having the defect or the paralysis will be on the right side of the patient. So and also the patient will be having a language and speech problems, decreased auditory memory, slow, cautious, disorganized behavior, memory deficits will be there, and also the patient will be anxious. So what are the stroke diagnosis? So when a patient is going to have a stroke, how you early you are going to find out the diagnosis? The patient can be immediately shifted to an emergency medical services, and also the patient can be given a immediate treatment. So what are the signs and symptoms? Cincinnati pre-hospital stroke scale has been given, where the patient will be having an facial droop. So when you call it as facial droop, usually in normal patients, both sides of the face move equally. But in this kind of stroke patients, I have a video showing that how the patient's facial movements will be. So abnormal, one side of the face does not move as well as the other. So one side of the patient's face will be moving, and the other side of the face, the patient's facial muscles will not be active. So the patient will be having arm drift. So when the patient is normal, both the arms move the same or both the arms do not move at all. So in those conditions, when the patient is having a stroke, we ask the patient to lift both the arms. The patient will be having one arm does not move and drifts down compared to the other one. Moving on to speech, the patient will be when the patient is normal, says correct words and no slurring will be there. But when the patient is going to be abnormal or the patient is going to have an stroke, the patient will slur words, says the wrong words, or is unable to speak. So these are the early signs or the pre-stroke signs, so which we should elicit very fast and then we have to act quickly. So this is an patient who had a stroke. Who reported to our OP. So the patient was thankful enough to give a video depicting the stroke disabilities following a stroke. I want to thank my PG, Dr. Vijita, for helping me out in taking out this video.
Close your eyes tightly, tightly. Puff, puff your cheek.
So in this video, you can see that the patient's movements of the face has been possible on the right side, and the patient's muscle activity is less on the left side. So once again, if you see the video, the patient is able to make a wrinkle of the forehead on the right side, but the left side is not possible. And when the patient tries to close the eyes tightly, right side the patient can do the closure of the eye tightly, but the left side he cannot do it. The same way when he is doing then puffing of the thing or holding up the air, the patient is able to make it out on the right side, but on the left side there's an escape of air, and also the patient is having an uh, uh, difference in the facial expression on the right side and left side. So the left side is the patient's affected side. Mostly the right side brain would have been affected. So left side the muscle weakness is there, where the patient's muscle is not moving. But usually when the patient try to move, you can see that the normal side looks more different than the left side, I mean opposite side. So usually when there is a weakness, the face will be staying that static will be there, and the other movements will be seen on the opposite side. So, what are the signs and symptoms of an ischemic stroke? There will be sudden numbness or weakness of the face, arm, or a leg on one side of the body, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one eyes or both eyes will be there, sudden trouble walking, dizziness, loss of balance or coordination will be there, and sudden severe headache with no known cause will be there. So these are the things which will be having the signs and symptoms. All of a sudden, it will be a sudden. Why you are adding up the word sudden means it will be in a fraction of a second. So like what the patient might be working on an computer, or the patient would have been watching a TV, or the patient would have been doing any other work. Suddenly, the patient collapses. So that is the condition you want to know. It will be in sudden in onset, and we should be very early to pick up the signs and symptoms so that we have to act immediately to shift the patient for an emergency medical services. So what is why you are more alarming of this is a life-threatening emergency. So when you are not going to pick up the signs early, the patient life is at a threat. So when you what is the need for it is to emergency healthcare provider must be recognize the importance of the symptoms early and also respond quickly with medical or surgical interventions. So, what are the signs and symptoms of hemorrhagic stroke? So, what are the things we have seen earlier is an ischemic stroke. Now we see about the hemorrhagic stroke. There is no much difference between hemorrhagic and ischemic stroke. There will be similar presentation of the signs and symptoms for the ischemic stroke, and certain distinguishing features will be there. That is, appear more seriously ill. The patient deteriorate more rapidly. Severe headache will be there. Alteration in consciousness will be there. Nausea and vomiting is the positive sign, and the neck pain will be there. And intolerance of noise or light will be seen in the cases the patient is having an hemorrhagic stroke, which will be having a burst of an vessel inside the brain. So another condition is there where you have the transient ischemic attack, so which is not a stroke and it is almost called as a mini stroke or temporary stroke. What are signs and symptoms? It will be mostly similar to the complete stroke, but it will last for few minutes to several hours before resolving. TIA is a forecaster for impending stroke. So when you have an TIA, the transient ischemic attack, the patient has to immediately go and see a doctor so that the major strokes can be avoided. So when you move on to the stroke chain of survival, so the American Stroke Association, like what you have in the American Heart Association, we have an American Stroke Association. So they have given us 7 Ds. So how a patient can survive in a stroke condition. So what is called as the direction. So recognition of the stroke signs and symptoms is very, very important. And if you can easily recognize it easily, then you can call 911 and the priority EMS dispatch can be called for. So delivery, so this is a prompt transport and pre-hospital notification to the hospital is very, very important because whenever you have an stroke patient, you have to have a neuro ICU. So neurosurgeons must be stationed or neurologist has to be stationed in the hospital so that they can be immediately attended by the doctors. So once the patient is delivered to the door or the patient has been taken to the hospital, immediate ED triage is very, very important. The emergency department has to act so quick. And also, emergency department evaluation, prompt laboratory studies, and CT imaging has to be done. So after that, the diagnosis and decisions about the appropriate therapy has to be done, so that you can start on the medications. Then administration of the appropriate drugs or the other interventions can be done. So we have a flow chart how to manage the patient in stroke. I'll just let you know. So the 7 Ds are very, very important too for the patient on stroke to survive. So, what are the guidelines of an emergency medical service management of patients with a suspected stroke? So, when the patient has been recognized, the patient has to be shifted to hospital. So, the in between gap, what can be done is you can manage ABCs, cardiac monitoring has to be done, intravenous access for hypoglycemia. So NPO is always to be maintained because there can be chance whether the patient is going to be taken up surgery or any chance of nausea and everything is to be there. So there can be chance of an aspiration pneumonia. To avoid that, always keep the patient on NPO. Don't feed the patient. Alert receiving the emergency department by informing that the stroke patient has been taken into the emergency department will be reaching soon. And rapid transport to closest appropriate facility capable of treating acute stroke. So the thing has to be having a neuro ICU and a neurologist who can meet the patient or review a patient immediately. And also oxygen as required has to be maintained in the saturation level of not less than 92%. And what is not recommended is whenever you shift the patient, don't give dextrose containing fluid in non-hypoglycemic patients. So the patient is normal patient and he is not an hypoglycemic patient, don't give dextrose. And also check for the hypotension or excessive blood pressure reduction. Don't give excessive intravenous fluids. So these all has to be not to be done during shifting the patient to a hospital. So this is a small algorithm showing how you are going to try the patient or what to be done when the patient has reached the hospital. So if you are going to be consider the patient is going to be suspected for a stroke, just to identify whether it's an acute ischemic stroke or it's going to be hemorrhagic stroke. Usually it's acute ischemic stroke, it will be 85%, mostly it will be an acute ischemic stroke. So when you have to find out whether the onset of symptoms within uh, 3 to 4.5 hours, 3 hours, other starting from 0 to 3 hours. So if it's going to be there, then you have to take a CT head and also you have to give an IV recombinant tissue plasminogen activator. So RTPA is if the patient is eligible patient, and then you have to shift the patient for a CT angiogram head and neck. So that has to be done. If the onset of symptoms is within 4.5 to 24 hours, that is a little bit delayed, then directly shift the patient for an CT angiogram head and neck. And then to rule out main problem is the large vessel occlusion. Whether the patient is having a large vessel occlusion has to be monitored in the CT angiogram. If the CT angiogram is saying no, then shift the patient to neuro intensive care unit. If the patient having a large vessel occlusion, then you have to go for two things. One is you have to repeat the CT or MRI perfusion scan can be done. So initially the LVO has to have an if it's going to be 6 hours, there's no need for advanced imaging. If the thing is going to be 6 to 24 hours, then you have to go for a CT or MRI perfusion scan. If the patient is eligible, then the patient can be taken up for a mechanical thrombectomy. If the patient is non-eligible, then you exactly shift the patient to neuro-intensive care. If there is a hemorrhagic stroke, directly shift the patient to a neuro-intensive care unit. This is a small flow chart depicting what had to be done for the patient. So moving on to the prevention. So moving on to the medical management. So medical management first is your prevention. So if you can prevent the stroke, it is better. So prevention is better than cure. So always keep in that mind that when the patient is going to be a stroke, always try or to be patients about in the condition of pre-stroke, always try to prevent it out. So prevention by identifying the risk factors in individuals to be careful, like the patient is going to be having hypertension, uncontrolled hypertension, or hypoglycemic patient, or the patients with the stress condition. Those patient has to be identified, and the risk factors has to be explained to the patients. And also you can reduce the BP by antiplatelet therapy and a statin, which can reduce the secondary stroke prevention. When the patient is going to have a reduced 10 mm of Hg, like systolic blood pressure can be reduced by 10 millimeter of mercury, there can be one third the reduction in risk of a stroke. So always try to reduce the systolic blood pressure by 10 milligram as much as possible. And the tablets like aspirin and triclopyr will be having can be used as a preventive therapies for ischemic stroke patients. And taken with a baby aspirin or a patient is on aspirin with 325 milligram daily reduces the stroke by 25% in the patient at risk. So this is the medicines that can be advised when the patient is at risk. So it can prevent the stroke. So once the patient has done a stroke, so four things to be taken into account. So one is the immediate task, which is always to sustain the life during the period immediately after the stroke. So we want to sustain their life. So we don't want to lose the patient. So we have to sustain the life during the period immediately after the stroke. Second task is attempt to lyse the clot and to prevent further thrombosis or embolism. So you try to give some medicines so that you can lyse the clot. So third and final task is preventive therapy. So administration of a medicine to reduce the risk of another stroke. So you have to make the patient on a long-term tablets of anticoagulants or antiplatelet therapy so that the patient doesn't have another stroke in the following years. Following which all these conditions, the patient will be having an problem with permanent disabilities. So the patient has to go for a rehabilitation. So rehabilitation will be like intense physical physiotherapy, occupational, and the speech therapy if needed. So these all has to be done so that the patient's life will be having a better outcomes. So moving on to the dental management of patient with strokes. Whenever you see a patient who is suspected to be stroke, identify the risk factors. So when the patient is going to have an hypertension more than 200 systolic high blood pressure, always those patients are at the risk of a stroke. So always try to be careful when you are going to identify these patients. So hypertension patient, congestive heart failure patient, diabetic mellitus patient, or the patients having an had an history of TAA, that is transient ischemic attack, or previous stroke, they are at the risk. And when the patient's age is more than 75, they are also at the risk of stroke, elevated blood cholesterol, coronary atherosclerosis, cigarette smoking. So these are the patients who can go for a stroke on the dental chair. So these patients has to be taken extra care. And if you find out a patient who is not under the medication for an systemic hypertension and the systolic blood pressure is going to be more than 200, always encourage the patient to control the risk factors by sending the patient to a physician so that the patient can be taken care of. Obtain a thorough history of stroke. So when a patient is going to give a history of stroke, like the video what I showed, the patient was an known his patient of stroke. So we had the precautions what to be done when the patients came with the stroke history. So actually eventually we couldn't find out by normal this. So what we did is the patient when the patient walked in the gate, we found out there's a difference in the gait. So we had a question like what is the problem you're having in the altered gait? Then the patient said I had a history of stroke because with the face movements we couldn't find out the patient perfectly. So the major problem was with this gait. So we identified him and asked him. So he said that is a problem with his disability following a stroke. So when you are obtaining a thorough history of the stroke, you have to get the date of the event, current status, medical therapy, and also the residual deformities he has been following residual families may be suffering after the stroke. Provide only urgent dental care in the first 6 months after stroke. So whenever the patients come with a stroke, if the patient needs a treatment, an urgent dental care can be done in the first 6 months after the stroke because there is a patient who can have an a second stroke or another stroke can happen when the patient is going to be treated in the 6 months, less than 6 months after the stroke, and also a patient having a TIA or a RIND. So RIND is an reversible neurological deficit, ischemic neurological deficit. So what we call as RIND is reversible ischemic neurological deficit. So avoid elective care in patients with the recent TIA or IND. So always try to avoid elective care for the patients in need for TIA or IND. So only in emergency case you do the treatments. Disc Determine the risk of bleeding. So whenever this type of patient comes to our clinic or OP, we should be very careful with doing what are the treatments we are going to provide for the patient because the patient will be on an long-term antiplatelet or anticoagulant therapy, so which can be having an bleeding tendency. So to minimize the perioperative bleeding, you should be taking care of certain things like when the patient on clopidogrel or combination drugs, always obtain a pre-treatment platelet functional analysis, which is going to give you about 100%. Then with the patients on anticoagulants like coumarins, so always have a pre-treatment INR which should be less than 3.5. So if it's going to be more than 3.5, there is always a tendency that is going to be excessive bleed where you cannot arrest the bleeding. So when the patient's on a heparin, use the palliative emergency dental care. Discontinue the heparin 6 to 12 hours before the procedure, and you can give an alternate medicine like coumarin during the procedures, and start the heparin after 6 hours of the dental procedure. Use measures that minimize the hemorrhage, like always try to do an atraumatic extraction and also give all the medical, hemostatic agents by the sites. Use non-adrenergic hemostatic agents like electrocautery for arresting the bleeding from the sockets and other things. Usually schedule a short, stress-free mid-morning appointment for the patients. Monitor the BP and oxygen saturation while during the procedure for the patient. Minimum amount of LA with vasoconstrictor should be used. Avoid epinephrine in the retraction cord. Recognize the signs and symptoms of the stroke early. Provide emergency care and activate the emergency medical services immediately as soon as you recognize the sign of stroke. So, what are the effective communication techniques for patients with stroke? So, when you are addressing a stroke patient, what are the things you should carefully be handling out when you're doing this type of patient? Always face the patient. Use slower, more deliberate, less complex pattern of speech. Communicate the patient on eye level. Always given closed-end questions like make the patient to answer yes or no, so that you can be simple and brief. Give frequent, accurate, and immediate feedbacks to the patient, like how they are going to respond for this. So use simple drawings to explain the procedures. Do not underestimate or overestimate their abilities. Do not raise your voice or use a baby talk. Do not wear a mask when talking to the patient. So these are the things you have to keep in mind when you're so that you don't hurt the patient and you get the proper medical history from the patient. So what are the oral complication manifestations seen in the cases with stroke patients are slurred speech, patient have a difficulty in swallowing, unilateral paralysis of the orofacial musculature will be there, loss of sensory stimuli of oral tissues will be there, the tongue will be flaccid, multiple folds will be there, and a deviating on extrusion. When the tongue is trying to be done for an extrusion, there can be a deviation will be seen. Dysphagia, difficulty in managing with the liquids and solids will be there. Food and debris accumulation is seen mostly on the tooth and also on the floor of the mouth can be seen on these cases. The patient has to need to learn a clean the teeth or dentures with one hand or many may need an assistance. Periodontal disease and halitosis will be there, and periodontal treatment reduces serum inflammatory markers potentially involved in stroke. So these are the oral complication manifestations can be seen on the stroke patients. So on the conclusion, I want to say that stroke can happen at any time on any patients. So always try to be careful when you early detect the stroke and you call upon an emergency medical service as soon as possible. The patient's life is saved, and also you can reduce the amount of disability the patient will encounter after the stroke. So always be careful when you're treating the stroke patients. So this is want to sign off. So thank you. So